Hi, this is the NUR-PNR 170 recorded lecture for gas exchange. Here are the objectives for this particular presentation: to identify the concept for nursing practice, identify focused assessment, nursing diagnoses, potential complications, nursing interventions and their rationale, identify patient and family teaching for gas exchange, and identify possible medications and treatments administered for preventative care, and also to discuss patient outcomes. So let's define what is gas exchange. Gas exchange is the process by which oxygen is transported to the cells and carbon dioxide is transported from the cells. Here's a review of the respiratory system. I also recommend that you watch the little video that is posted on Moodle that basically gives a brief description of the anatomy and the basic physiology of the respiratory system. It really helps to kind of just refresh your memory on how everything works. In this particular one, this particular slide, it shows you that the upper respiratory tract consists of the nose, the mouth, the pharynx, the epiglottis, the larynx, and the trachea. And the lower respiratory tract consists of the bronchi, the bronchioles, the alveolar ducts, and the alveoli. And of course, then there's the lung lobes. So some definitions for oxygenation that you might hear and you need to be familiar with is spirometry, which is the measure of the volume of air entering or leaving the lungs. Tidal volume is the amount of air exhaled in a normal breath and assumed to equate with the amount of air inhaled with each breath. And then pulmonary circulation, which is the movement of blood to and from the alveolar capillary membrane for gas exchange. There's a reservoir for blood so that the lung is able to increase its blood volume without large increases in the pulmonary artery or venous pressure. It acts basically as a filter to remove small thrombi before reaching vital organs. So let's talk about respiratory physiology. Basically, the exchange of respiratory gases occurs between the environment and the blood. So the lungs transfer oxygen from the atmosphere to the alveoli, where the oxygen is exchanged for carbon dioxide. The alveoli transfer the oxygen and carbon dioxide to and from the blood through the alveolar capillary membrane. There are 3 steps in that process, and those are ventilation, perfusion, and diffusion. And again, if you review that small, I think it's only about 1.5 minutes long video, it really helps to describe how this process takes place. So when we look at ventilation, what is ventilation? Well, the ventilation is the process of moving gases into and out of the lung. So we do that from inspiration and expiration. So that's an active process stimulated by chemical receptors in the aorta, and a passive process for expiration. So the receptors that you have are stimulated to take a deep breath in are by chemical receptors in the aorta, and then to breathe out should be more passive. You shouldn't have to use your intercostal muscles. So then there's pulmonary circulation, which moves blood to and from the alveolar capillary membrane for that gas exchange to take place, and they do that through diffusion, the exchange of respiratory gases in the alveoli and the capillaries. Then, of course, oxygen transport goes from the lungs to the cardiovascular system, and then the carbon dioxide transport diffuses into the red blood cells, and it's hydrated into carbonic acid and expelled out the mouth and the nose. So work of breathing is an important concept that you need to be familiar with. That is the effort required to expand and contract the lungs. So work of breathing can be a method of describing someone who is breathing well, they're not having a heavy work of breathing, or someone who's having a more difficult time. So inspiration obviously is the active process, and that, what we said in the previous slide, is stimulated by receptors in the aorta. And then expiration is a passive process, which I mentioned in the other slide as well, and that depends on the elastic recoil properties of the lungs. It should require little or no muscle work. Compliance is the ability of the lungs to distend or expand in response to increased intra-alveolar pressure, It decreases in diseases including pulmonary edema, interstitial and pleural fibrosis, and congenital or structural abnormalities, such as fractured ribs. Airway resistance is the pressure difference between the mouth and the alveoli in relation to the rate of flow of inspired gases. Airway obstruction, asthma, tracheal edema, which help increase airway resistance. When airway resistance increases, the amount of air traveling through the anatomical airways decreases. So we don't want that pressure. So the process of gas exchange, this is just a little slide that you can see what goes on and where it happens and how we inspire and transport oxygen and how we expire and transport CO2 back into the atmosphere. When we are talking about respiratory assessment or respiratory problems, we need to do focused assessments. And what we would do is we need to look at subjective data, which includes their past medical history and any medications they're on, surgical treatments, what is their perception of health, what is their nutrition like, their elimination pattern. We look at all those factors. And when we go to the objective, we look at physical examinations, we look at their nose, is there any deviation, are they having any deviated septum or are having difficulty breathing through one nostril or the other nostril. We look at their mouth and their pharynx, their neck. Then, of course, we look at the thorax and lungs. We do that with inspection, palpation, and auscultation. And I know that in the lab, you all were practicing auscultation, excuse me. So remember, there are two normal breath sounds. There's bronchial and vesicular. Breath sounds can be heard over the tracheobronchial tree. Those are called bronchial breathing. And the breath sounds heard over the lung tissues are called vesicular breathing. So sometimes you'll see people listening in the thoracic, in the trachea area, and they will hear breath sounds. And those are normal bronchial breath sounds. So when you do hear those, there's nothing that you should be concerned with. You want to document your findings because that's normal breath sounds. So, assessment, if you're listening to lung sounds, you want to see if there's abnormal breath sounds. Another word for abnormal breath sounds are adventitious sounds. You will hear things like fine crackles, coarse crackles, wheezes, stridor, or pleural friction rub. So underneath this particular slide, it gives a description of what those adventitious breath sounds should sound like or similar to. Like fine crackles, they are a series of short durations, discontinuous, high-pitched sounds heard just before the end of inspiration. It sounds similar to if you rolled your hair behind your ear, that type of thing. And coarse crackles are a series of long-duration, discontinuous, low-pitched sounds caused by air passing through air intermittently, occluded by mucus, unstable bronchial wall, or fold of mucosa. It's usually evident on inspiration and sometimes in expiration. Those are similar to sound of you blowing through a straw underwater, and they increase in bubbly quality with more fluid. Wheezes are the continuous high-pitched squeaking or musical sounds caused by rapid vibration of bronchial walls. It usually, you first will start hearing them on a patient during expiration, but eventually it can, you might be able to hear them on inspiration. A stridor is a continuous musical or crowing sound of constant pitch, results of partial obstruction of the larynx and trachea, and you often hear that when next semester we're going to talk about it a little bit more in pediatrics with people with croup, things like that. Pleural friction rub is a creaking or grating sound from a roughened, inflamed pleural surface rubbing together. This is evident during inspiration and expiration, and may have no change in coughing. It's very uncomfortable for many people. So populations at risk are infants, children, and older adults. And infants and children, for the mere fact that their immune systems are developing. They're exposed to a lot of viruses and infections that they don't have immunity to. And also in infants, their system is still developing. In older adults, the effects of aging on their cilia on their musculature and their immune system. So other factors affecting respiration, physiological factors, which could be decreased oxygen carrying capacities, decreased inspired oxygen, hypovolemia, so extracellular fluid loss or reduced circulating blood volume can relate or can affect breathing and your gas exchange, or increased metabolic rate. Also, conditions affecting chest wall movement, such as pregnancy, obesity, musculoskeletal abnormalities, trauma, neuromuscular diseases, and central nervous system alterations. Individual risk factors include age, smoking. Smoking, I always stress, is just not a positive trait to have and very damaging to the body. And it's not just smoking tobacco. Other methods of breathing in smoke and polluting the lung is smoking marijuana, smoking any type of smoke, being exposed to smoke outside, things like that can be damaging. But someone who's actually smoking on a daily basis, like a pack a day, they're doing quite a bit of damage to their lungs. Presence of chronic medical conditions such as chronic obstructive pulmonary disease, which we'll talk to in a little bit, cystic fibrosis, which we'll talk to about next semester, and heart failure, which we'll also get more in depth talking about next semester. People with immunosuppression, those in reduced state of cognition, so people with dementia, confusion, brain injury, or those with prolonged mobility are also at risk. Some of the common diagnostic lab tests that you will see. They usually do an arterial blood gas. That is a test that takes basically a sample from your arterial blood, and it measures the level of oxygen and carbon dioxide in your blood, and it also checks for the pH of your blood to see if you're more acidic, more alkalytic. So that gets very specific. Remember, we do one of our O2 sats that we do all the time on the finger, or you can do it on the toe or on your earlobe, on the nose, those type of things to get a reading of the oxygen saturation in your blood. That's pretty non-invasive, and that's pretty routine that we do now. We didn't do that routinely at all back in the early days, and blood gases were pretty much the method and mode of getting the saturation of oxygen. Complete blood counts is another laboratory test that we would complete, looking at WBCs to see if there's any infections going on, looking at hematocrit and hemoglobin. A low level might indicate, obviously, they're not getting enough oxygenation in the blood. Sputum to see if there's some type of bacterial or infection going on in the lung, and biopsies, which obviously they're testing the tissue to see if there's a malignancy or something else going on with the tissue. X-rays or radiological studies, which include chest X-rays, CAT scans, MRI scans, ventilation and perfusion scans, positron emission tomography, which is a PET scan, pulmonary function tests, and also endoscopy. When you do an endoscopy for the lungs, it's called a bronchoscopy, and a bronchoscopy can be done with a rigid type of bronchoscope or a flexible tube, very similar to what you'd see with a gastroscope, only much narrower because it's going down into the lung area and it's looking at the trachea and it basically is looking to see any types of issues that they can see within the lung itself. Okay. Clinical management. So we want to prevent first. So prevention of any problems with respiratory is to infection control. What do we know about infection control? We talk about this all the time. Some of the basic modes of controlling infection is hand washing. We saw with COVID that sometimes if it's a droplet type of illness that's being spread, we would wear masks, things like that to help prevent infection. Smoking cessation, very important, because that can contribute to a progressive condition, which we're going to be talking to in a little bit, damaging the lungs and not being able to get the the same capacity that your lungs had when they were healthy. Immunizations, obviously immunizations are important in preventing, as we see with influenza, with the pneumococcal one, and now more recently with the COVID vaccines, and preventing post-operative complications. And most of you who have had an experience with rehab facilities have been able to utilize certain methods with coughing and deep breathing, incentive spirometry, up and about moving, that type of thing, to prevent postoperative complications on respiratory. Let's see. Okay. Next thing is clinical management, collaborative interventions. So we want to, of course, smoking cessation. They will use pharmacotherapy types of medications. So they'll use like bronchodilators, which would include like albuterol. They might use steroids, nutrition therapy, positioning. How do we position someone who's having a problem with respiratory? Usually with the head of the bed elevated, either high Fowlers in at least 30 to 45 degrees when someone's having respiratory problems. But sometimes you need to move them even higher up. That takes less pressure off of the intercostal muscles. And also you've seen patients assume the tripod position, which helps open up the airway and makes it easier for them to breathe. Chest physiotherapy, which is essentially trying to loosen up the mucus and secretions, and you see that oftentimes used with people who have cystic fibrosis and with COPD. Postural drainage to help encourage drainage of the mucus. Other things that may be utilized is oxygen therapy devices, and you saw in your lab how the different modes and methods of how that's distributed, how that's given to patients, via mask, via nasal cannula, things like that. Airway suctioning you also saw. There is, of course, just mouth suctioning, but we see deep suctioning as well, and that can be done through the nose, through the mouth, through a trach, those different methods. Endotracheal tubes may be in place, and you saw what those are. We saw the laryngoscope that they utilize so that they can make sure they're in the correct tube or pipe, as my mother used to always call it. So that would be the endotracheal tube. We look to see if we can see the vocal cords, and then they would insert an endotracheal tube that would be the correct size for the particular patient. And that would be to open up the airways and make sure that we're getting proper gas exchange to someone who's been in a trauma or someone who's having a difficult time breathing. If it's going to be long term, they will do a tracheostomy tubes. Mechanical intubation is also another method, and chest tube management. If someone had a collapsed lung, they would be using a chest tube, and you'll learn more about that in your senior year. Alterations in respiratory functioning. There's hyperventilation, which is ventilation in excess of that required to eliminate carbon dioxide produced by cellular metabolism. Hypoventilation is the alveolar ventilation inadequate to meet the body's oxygen demand or to eliminate sufficient carbon dioxide. Hypoxia is inadequate tissue oxygenation at the cellular level resulting from deficiency of oxygen and delivery or oxygen utilization at the cellular level. And cyanosis is a blue discoloration of the skin and mucous membranes. So again, we're back to developmental factors for some of these alterations in respiratory functioning. And we see infants and toddlers are high risk, and they're at risk for upper respiratory infections from exposures to others and secondhand cigarette smoke. Teething can cause an increased risk for URIs because this increased nasal congestion, which basically encourages bacterial growth. School-age children and adolescents also are more prone to URIs, sometimes secondary to secondhand smoke, and they can actually start smoking. We start seeing kids sometimes smoking very young. In particular, they start smoking and thinking it's a cool thing to do in middle school, so sometimes we see that, or middle school or the beginning of high school. Young and middle-aged adults, we start to see coronary artery disease, risk factors, diet and nutrition, lack of exercise, stress. Management of stress is very important to prevent respiratory difficulties and cardiovascular disease. And also they start to use illegal substances and smoking. So we know that with opioids, it does suppress the breathing, and that's something that we're seeing as an epidemic in today's society. And most of the people who actually overdose have overdosed to the point where they have suppressed their breathing or stopped their breathing. So that's something that's very important to educate people or adults and young adults and middle-aged adults about, and adolescents. So older adults, it's age-related changes, calcification of the heart valves, the SA node, costal cartilages, arterial system develops where they have arterial sclerosis, osteoporosis, changes in size and shape of the thorax, the trachea and large bronchi become sometimes calcified and enlarged, the alveoli enlarge, decreasing the surface area for gas exchange, their functional cilia reduced, causing less effective coughing and putting them at risk for respiratory infections. So those are definitely some factors that we see affecting respiratory status. Lifestyle risks, again, this is a redundance in a sense. Nutrition, exercise, smoking cessation, substance abuse, and stress reduction. So assessment history, we want to look at pain, if the person has any pain with breathing, any dyspnea, shortness of breath, if they have any wheezing, respiratory infections, health risks, smoking, cough, environmental or geographical exposures, allergies, or medications. Nursing diagnoses. Some of that you'd see would be activity intolerance, decreased cardiac output, impaired gas exchange, impaired spontaneous ventilation, impaired verbal communication, ineffective airway clearance, ineffective breathing pattern, or risk for infection. So those are some that you might see when you're looking at your patient. And they would be highly individualized for your patient. Nursing goals and outcomes. These are some of the things that you'd see. Client's lungs are clear to auscultation. Client achieves bilateral lung expansion. Client coughs productively. Pulse oximetry is maintained or improved. And as you take care of your patient, they'll be very specific to your patient, and you'll be able to come up with the particular goals that are appropriate for the patient and the respiratory issues that they have at hand. Some implementation or interventions would be vaccinations, which we mentioned before, influenza, pneumococcal, health style, eliminating risk factors, the smoking that I always talk about, eating right, regular exercise, trying to reduce their exposure to environmental pollutants such as secondhand smoke or any chemicals or pollutants with work or where they're close to where they live, and stress reduction should be also on there. Dyspnea management. So dyspnea is difficult to measure and treat, and treatments are individualized, and more than on therapy can be implemented. So we want to basically look at their airway management. We want to be able to mobilize pulmonary secretions, offer humidification, nebulization, and chest physiotherapy. Suctioning. As we mentioned, and as you saw in lab, there is oropharyngeal suctioning, nasopharyngeal suctioning, orotracheal, nasotracheal, and tracheal. Artificial airways that you saw hopefully in lab, in the show and tell, those are oral airways, and they will prevent obstruction of the trachea. They basically, and by the displacement of the tongue, it prevents the tongue from blocking. There's endotracheal airways, which are short-term use to ventilate, and tracheostomy, which we talked to earlier as well. Maintenance and promoting lung expansion, positioning, incentive spirometry, and chest tubes are some of those. Promoting oxygenation, oxygen therapy, The methods of supply we see is nasal cannula and oxygen. Restoring would be cardiopulmonary rehab, very important. They try to, basically they're teaching the client to breathe more effectively during activities of daily living, things like that. Hydration, teaching coughing techniques, pursed lip breathing, which is just as it sounds, making your, almost like you're going to be kissing your lips and you're blowing out slowly. And diaphragmatic breathing, using your diaphragm. So now that we know basic things about the respiratory system and some ways that we can assess and treat alterations in it, let's talk about specific lung diseases. And in this particular lecture, we're going to talk about obstructive pulmonary diseases, which include asthma, and COPD. Other ones would be cystic fibrosis and bronchiectasis, but we'll talk about those next semester, cystic fibrosis and bronchiectasis. But in this lecture, we're going to talk about asthma and COPD, which is chronic obstructive pulmonary disease. The first one we're going to talk about is asthma. So the definition of asthma is it's a chronic inflammatory disorder of airways causing airway hyperresponsiveness, leading to wheezing, breathlessness, chest tightness, and coughs. Asthma affects about 16 million Americans, with 66% more women likely to have it than men. Older adults are oftentimes undiagnosed because we see it a lot of times in pediatrics. And we will actually review or go over this again, asthma, even more in depth next semester. But it's good to have a basic understanding of what asthma is for when you're dealing with, especially now that you're dealing with a lot of children who may have it within the schools. This is what your bronchus will look like when you have an asthma attack. So normally this should be nice and clear here. Let me see if I can get my little mouse. And you can see that as it gets inflamed and mucus starts to form, you can see that this is not opened and clear. So we're going to try to get air in and it will get trapped on the way out and cause difficulty getting proper gas exchange. Some asthma factors and triggers can be genetics. We do see that it runs in families and that there's a genetic factor that is plays a factor in this. It's immune response. Oftentimes it's just you have some type of infection and your body fights, and we see the lungs responding that way. Allergens such as dust mites, cockroaches, mold, animal dander, fungi. A lot of the times people will get an asthma attack based on the allergens. Sometimes people have what's called exercise-induced asthma, and that's just overdoing it, and all of a sudden it puts them into an asthma attack. Air pollutants such as smog, pollution, sulfur dioxide, elevated ozone levels, and cigarette smoking. Occupational factors can also especially when the occupation is with exposure to some air pollutants. Respiratory infections and nose and sinus problems are also triggers. Other triggers can be food and drug additives, which you can have a sensitivity to. May not be an allergic response, but it's a sensitivity to it. They find GERD, which is gastroesophageal reflux disease, and they believe that that can cause sometimes a person to aspirate the gastric contents into the lung, causing a asthma trigger. And psychological factors. You'll see people who are panic or have panic attacks or very high anxiety. And so we do see sometimes asthma attacks being happening with those people. So the pathophysiology, its primary response is a chronic inflammation from exposure to allergens and irritants. Again, this is almost like the definition, leading to airway hyperresponsiveness and acute airflow limitations. So inflammatory mediators cause early phase response, so there's a vascular congestion, which thus follows edema formation, and then the production of thick, tenacious mucus, bronchial muscle spasms, and thickening of the airway walls. So you can see, just listening to that and hearing what that entails, of course, it's going to be difficult to pass air to and into and out of the airway passages. Continuing with with pathophysiology, the late phase response occurs within 4 to 10 hours after the initial attack occurs, and it only occurs in 30 to 50% of patients. It can be more severe than early phase and can last for 24 hours. If late phase response for airway inflammation is not treated or does not resolve, it may lead to irreversible lung damage, and thus a condition that we're going to be talking about soon. Respiratory infections are the major precipitating factor of an acute asthma attack, which basically it increases inflammation and hyperresponsiveness of the tracheobronchial system. Clinical manifestations continued. We have expirations may be prolonged, inspiration to expiration ratio of 1 to 2, 1 to 3, or 1 to 4. So there's a bronchospasm again. We're getting a spasm there. We're getting edema. We're getting increased mucus in the bronchioles, so they get narrow and they're getting blocked, and it causes air to take longer to move out. So we have what's called air trapping. When we're trying, they usually are hearing wheezing, but not always is wheezing audible. So, but when we do hear the wheezing, we usually hear it initially in the expiration of when you're listening to lung sounds. It is unpredictable and it is variable. Recurrent episodes of wheezing and breathlessness and cough and tight chest occur, but not all asthma has the wheezing, as we said. Sometimes there's an asthma that we just are hearing the coughing. An attack can be abrupt or gradual, and it can last minutes to hours. Again, there's difficulty with air movement. It can create a feeling of suffocation, so the patients become anxious, contributing even further to gas exchange being impaired. So it's very imperative that you keep the patient calm. An acute attack can cause hypoxemia. You'll see restlessness, so therefore they're having increased anxiety. Inappropriate behavior, you'll see that, especially if you're in the schools and you're taking care of someone who comes in with an asthma attack. Usually you see them becoming very, very tense and afraid. And thus, with all this hard work that you're trying to do to get the respirations moving and getting oxygenation and the anxiety, you're getting an increased pulse and blood pressure. You might have pulsus paradoxus, which is a drop in systolic blood pressure during inspiratory cycle of greater than 10 millimeters of mercury. Basically, there are different classifications of asthma. You can have intermittent asthma, and that's just an asthma attack that doesn't happen too often, and you use medication as needed. It's mild, it's intermittent, it's not something that you have to take daily. Unlike persistent asthma, you may be taking daily medications, and they should be taking them. It's required. You could have acute asthma exacerbations and severe acute asthma and life-threatening asthma exacerbations. Complications, you can have a severe acute attack with respiratory rate greater than 30 respirations per minute, pulse greater than 120 per minute, a PEFR of 40% in the peak flow. These people are usually seen in the emergency department, or they should be hospitalized. Life-threatening asthma, they're too dyspneic to speak, they're perspiring profusely, they're drowsy, they're confused, they require hospital or ICU care. And it's also, we will see a condition, status asthmaticus, which is a medical emergency. And it is an extreme form of asthma exacerbation characterized by hypoxemia, hypercarbia, and secondary respiratory failure. How do we treat? Well, we oftentimes want to treat by preventing an attack. So how do we do that? We control or eliminate symptoms. We attain normal lung function. We restore normal activities and reduce or eliminate exacerbations and side effects of medications. Drug therapies, beta-2 adrenergic agonist drugs, they prevent and release of inflammatory mediators of mast cells. That includes Ventolin, ProAir, Xopenex. They will use methylxanthines. In particular, in the olden days, they used to often use theophylline as a control method. It has a bronchodilator. It has no effect on hyperresponsiveness, but it was one that they used pretty routinely. You don't see it used that much in today with a control of asthma. They also use anticholinergic drugs that block acetylcholine, such as ipratropium bromide, Atrovent, Spiriva. Anti-inflammatories, mast cell stabilizers such as cromolyn or Tolade. Leukotriene modifiers, which are potent bronchoconstrictors. They block the action of leukotrienes. They have bronchodilators and anti-inflammatory effects. Those include medications such as Singular, Zyflo, or Accolate. They also have anti-IgE, which decrease the circulating free IgE in the blood, and that is omalizumab or Xolair. Corticosteroids are also used. They reduce bronchial hyperresponsiveness, they decrease mucus production, and they suppress inflammatory response. Those examples are Advair, Dulera, Symbicort, Pulmicort. And they also have combination with anticholinergics, respiratory beta-2 agonists, corticosteroids, inhalants. One in particular medication that you'll see being administered to patients with asthma, as well as sometimes now with COPD, is a medication called Trelegy. And Trelegy is with 3, so it has 3 different modes of action. Some nursing diagnosis with people with asthma: ineffective airway clearance, anxiety, and deficient knowledge. So you will have, of course, the main priority is to get them to breathe and to decrease their anxieties. And after we've got them to breathe, we want to educate them on understanding what they need to do to prevent an exacerbation and what they need to do when an exacerbation or attack occurs. Nursing implementation. You want to do interventions to monitor respiratory and cardiovascular system. You want to decrease the patient's sense of panic, teach them to take slow, deep breaths, and to purse lip breathe. And also positioning. They can go into the tripod position to help them open their airway. The next condition we're going to talk about is COPD, which is it stands for chronic obstructive pulmonary disease. The definition of this is progressive airway limitations that is not fully reversible. It's progressive, meaning it continues and gets worse as time goes on. Abnormal inflammatory response of the lungs to noxious particles or gases. It is an umbrella term that includes conditions known as chronic bronchitis and emphysema, or a combination, because people can have a combination of both. I did put a video up again on Moodle on COPD. I feel like it's about 4 or 5 minutes, and it actually describes it pretty well. And it describes briefly the difference between emphysema and chronic bronchitis. But again, this is an umbrella term, and it includes you have one or the other or both of these conditions. It is the 4th leading cause of death in the United States, and it's more with women than men die from it. Death rates for Hispanics are lower than any other ethnic group. And here is a picture of what the lung looks like. So as in COPD, there is air trapping, and as air trapping increases, the walls of the alveoli are destroyed, and bulla or blebs can form. So a bulla is a permanent air-filled space within the lung parenchyma that is at least 1 centimeter in size and has a thin or poorly defined wall. And it is bordered only by remnants of the alveolar septae and or pleura. A pulmonary bleb is a small collection of air between the lungs and the outer surface of the lung, or the visceral pleura. It's usually found in the upper lobe of the lungs. When a bleb ruptures, the air escapes into the chest cavity and can cause a pneumothorax, which is air between the lungs and the chest cavity. And that can result in a collapsed lung. Here is a slide just to kind of show you the difference between chronic bronchitis to emphysema. These are kind of old terms. We do still have, they still use them. They are, like I said, classified under COPD, and when I said in an earlier slide. Sometimes they have them mutually exclusive, sometimes they have them together. But when you look at it, an emphysema person typically has, they call them pink puffers. And as you look at the picture right up here, you see this gentleman is thin, and he has a tone of pink. That pink tone is from the increase of CO2. They're in a chronic respiratory acidosis type of state. will look catechectic, and they will look like they have rosy skin tones. Adventitious sounds, you do have them. They're not as common as what you hear with a person with chronic bronchitis. Sputum, they may have some, not as much, which you will see with someone with chronic bronchitis. It's more copious. So as you can see the comparisons, and they will call someone with chronic bronchitis blue bloaters and pink puffers. So if you ever hear that term, you'll know what they're talking about for future. So the pathophysiology of COPD, it's irreversible airflow limitations during forces exhalation due to loss of elastic recoil. So there's airflow, obstruction due to mucus hypersecretion, mucosal edema, and bronchospasm. The primary process is inflammation. There's an inhalation of noxious particles. Mediators released cause damage to the lung tissue. Airways can become inflamed, and the parenchyma becomes destroyed. The supporting structures of the lungs are also destroyed. So air can go in easily, but remains in the lung. And the bronchioles tend to collapse, causing a barrel chest look. So you're going to see that oftentimes with people with COPD. They'll have a barrel chest. There are also pulmonary vascular changes. Blood vessels thicken. Surface area for diffusion of oxygen decreases. Common characteristics: mucus hypersecretion, dysfunction of the cilia, hyperinflation of the lungs, and of course, gas exchange abnormalities. You will have retention of CO2 because they are having problems getting air out. So they're having air trapping. What are the risk factors? Number one cause of COPD is cigarette smoking. So we want to try to encourage people to stop smoking. Occupational chemicals and dusts, air pollution, infections, and genetics. There is a gene, an alpha-1 antitrypsin gene in 3% of COPD cases. That's what they found, is that there's some type of genetic risk for them getting it. Cigarette smoking is significant because basically this is the number one cause. 80 to 90% of COPD deaths are related to tobacco smoke. The effects of nicotine, it might stimulate the sympathetic nervous system. It increases the heart rate, increases blood pressure, increases cardiac workload, causes peripheral vasoconstriction, increases platelet aggregation, decreases the amount of functional hemoglobin, and it compounds coronary artery disease. And as you'll learn when Liz is talking about peripheral vascular disease, obviously smoking is a terrible thing, a lot of times because of the smoke, but because of the nicotine effects too, causing peripheral vasoconstriction, causing problems. There's certain diseases that can be very much exacerbated or caused by cigarette smoking. So again, cigarette smoking, effects on respiratory tract, it increases the production of mucus, causes hyperplasia of the mucus glands, and it also is contributory to the loss or decreased ciliary activity. COPD clinical manifestations, it usually develops slowly. So people kind of notice something, but they get used to it, and they have this chronic cough, and then they are always coughing up sputum, and then they have shortness of breath, and so they have difficulty, and of course they've been exposed to risk factors. So what happens oftentimes, dyspnea prompts medical attention. They're getting short of breath with exertion in early stages. And then eventually, as the disease progresses, they become short of breath even at rest. Chest breathing, you'll start to see the person with COPD using accessory muscles and intercostal muscles. And even with that, they're having inefficient breathing. Typically, they start to look underweight with adequate caloric intake. They're eating enough for their body, but they look underweight, and they will suffer from chronic fatigue. And oftentimes people with COPD present as untidy, related to shortness of breath, because they are unable to perform their activities of daily living because they become short of breath. If you are looking at them in the physical exam, they will have prolonged expiratory phase. They might present with wheezes or decreased breath sounds. You will see an increase in anterior-posterior diameter. You'll also see them having polycythemia and cyanosis, or bluish color of the skin. Complications of COPD. So chronic obstructive pulmonary disease can lead to a condition called cor pulmonale, which is a hypertrophy of the right side of the heart. It results from pulmonary hypertension and late manifestations of chronic pulmonary heart disease, which eventually causes right-sided heart failure, dyspnea, distended neck veins, hepatomegaly, and epiquadrant tenderness, peripheral edema, and weight gain. COPD exacerbations is another complication where you have dyspnea, cough, sputum, and the poor outcomes. The primary cause of these exacerbations are infection and air pollution. They might have a complication of acute respiratory failure, which is it's related to the exacerbations, or copulmonale, or the fact that they discontinued using their inhalers, overuse of sedatives, or opioids, or benzodiazepines, and then sometimes surgery can institute that. People with COPD also have a complication of peptic ulcer disease. Recent studies strongly suggest that the major cause of hypersecretion of gastric juice is induced by hypoxemia or hypercapnia. So because a person in COPD have hypoxemia and hypercapnia, it seems to cause hypersecretion of the gastric juices, and thus a complication of COPD is a peptic ulcer disease, which you will learn more in depth about peptic ulcer disease in your senior year. Depression and anxiety is very, very prevalent in people with COPD. As you can imagine, if you can't perform activities of daily living without getting short of breath, then you would be depressed too. So a depression and anxiety are something that's very common complication of someone with COPD. Here is just the pathophysiology map that you can look at to see how this occurs and how it's a chain reaction and what leads to heart failure. So if you look at the chronic obstructive pulmonary disease, we see hypoxia and that over to the left, and we see acidosis and hypercapnia over to the right. With the hypoxia leads to polycythemia and pulmonary vasoconstriction and hyperviscosity, where the acidosis and hypercapnia lead to pulmonary vasoconstriction, which both sides lead to pulmonary vascular resistance, thus leading to pulmonary hypertension, and then leading to right ventricular hypertrophy, which leads to cor pulmonale and right-sided heart failure. So you can see that this complication is something that occurs quite frequently with someone with chronic obstructive pulmonary disease. Collaborative care. We want to prevent exacerbations and improve quality of life and reduce mortality. So what is the number one thing that we would try to encourage our patients to do who have COPD? We want them to quit smoking. Smoking cessation is the most effective intervention to help slow down the progression of this disease. Drug therapy, such as bronchodilators, anticholinergics, or inhaled corticosteroids. Oxygen therapy, which reduces the workload on the heart and reduces work of breathing. Remember that definition that we talked about at the beginning of this lecture. And nebulizers also are used. One thing that's important to take into consideration with a person with COPD is that there can be a complication of oxygen therapies. So we need to remember that oxygen is highly flammable, so it's combustible. So we want to avoid smoking and the use of petroleum-based products and being near open flames. So you need to educate your patients on the combustibility, because a lot of these people are going home on oxygen. Also, a condition called carbon dioxide narcosis is the retention of CO2, which can cause confusion, tremors, and coma possibility. Oxygen toxicity and hypercapnia. So basically that's when essentially you are giving too much oxygen. And it occurs with people with COPD in particular if you turn the oxygen too high. So typically someone who has COPD is on 2 liters of oxygen, and the theory behind that is twofold. One is that the receptors in the aorta typically are prone to stimulate breathing when someone becomes more hypoxic or when the level is low, so you inhale, and someone with COPD, that factor has changed, and that higher CO2 level gives them the drive to breathe. So too much oxygen at a higher concentration would prevent that desire to breathe or that natural ability or those receptors for responding properly. But also with the increased oxygenation, we're trapping more and more air and converting to CO2, causing more acidosis and more hypercapnia in the blood. Also, we could have absorption atelectasis, which refers to the loss of lung volume caused by the reabsorption of air within the alveoli, which are the small air sacs of the lung. Atelectasis is a common complication of surgeries that involve general anesthesia, but it can also occur in patients with too much oxygen or oxygen complications. Infection is another. The delivery of oxygen, especially when it's humidified, can create fomites and the aerosol that can spread the pathogens. Collaborative care continued. Surgical therapy they might utilize with someone with COPD, and that might be removal of the diseased lung to improve lung functioning. Breathing retraining, such as pursed lip breathing, things like that to help with decreasing the amount of air being trapped in the lungs. Airway clearance techniques like effective coughing and deep breathing, chest physiotherapy, postural drainage, percussions, vibrations, different types of devices that they might use. Sometimes a lung transplant can be performed for someone with COPD, which can help extend the life of a person with severe COPD, but the success rate is not as high for those with lung transplants as those who receive other types of organ transplants. So although it can help, you're not seeing people survive and have a quality of life like someone who might have a kidney transplant or a liver transplant. Some nursing diagnosis of someone with COPD: ineffective airway clearance, impaired gas exchange, imbalanced nutrition less than body requires, risk for infection, or insomnia. Some nursing implementations: we want to promote health. We want to utilize acute interventions. We want to make sure that they're ambulatory and that they have some home care. Pulmonary rehab is real important to help them learn breathing techniques in order to do activities of daily living, and also activity considerations. If their sexuality and sexual activity can be impeded, and that is an important part, especially of a young adult person who may have COPD. Sleep patterns are disturbed, and there's a lot of psychosocial considerations that you want to take into consideration when you are taking care of a person with COPD. So I hope if you have any questions or concerns, please feel free to contact me. I know that Liz is going to be reviewing the case study on a patient with COPD in class. So it's a good method to kind of utilize a way that you can implement nursing care for a patient with COPD. Again, if you have an opportunity, please watch those 2 short videos that are on Moodle. Thanks, and I hope you all have a great Thanksgiving.